The rotator cuff is a group of 4 muscles that surround the ball and socket joint. They help to motor the shoulder to create range of motion and strength. Rotator cuff tears are actually very, very common. In fact, most rotator cuff tears occur as we age. There's this expression that we often use, it's by someone called Atul Gawande, that says we're sort of rotting from the inside out. In other words, over time, rotator cuff tears occur decade by decade. Now, there is a subset of individuals who tear the tendon away from the bone, a so-called rotator cuff tear, after an acute event. These are typically younger patients who might dislocate their shoulder. It could be a traumatic injury. Patients go from no symptoms to significant pain and dysfunction and truly know they did something to their shoulder. Acute or new onset tears often are associated with recommendations for surgery. That's really a different category of a patient compared to someone who's had a long-standing rotator cuff tear whose symptoms begin over time with no specific identifiable event. The management of that patient is often very different. In my practice, my tendency is to do the least amount necessary to get someone better. Rotator cuff tears are a perfect example of how we can do that. In patients who present with shoulder pain, who don't identify a significant macro-traumatic event, whose MRIs show a rotator cuff tear that's likely been there for a prolonged period of time, we can suggest non-surgical care to eliminate their pain and normalize their function. The incidence of rotator cuff tears is very telling. In fact, every decade of life, another 10% of our population over the age of 40 will have a significant number of rotator cuff tears. In fact, it's been estimated that people over 60 may have a 10 to 15% incidence of having a rotator cuff tear. If you just look at the group over 60 alone, that means there's at least 6 or 7 million people in the United States walking around with a rotator cuff tear, yet we only fix about 500,000. Why is that the case? Because people learn to accommodate to a long-standing rotator cuff tear because the other muscles are functioning normally and they're in balance. Sometimes a pretty minor or an innocuous event will tip the scale where they become symptomatic. So it's important for me to understand the timing and onset of your symptoms, because if I identify that you've had a long-standing tear and only recently became symptomatic, I might suggest non-surgical care. Non-surgical care for rotator cuff abnormalities includes often a steroid injection and physical therapy. In fact, there is literature to show that up to 2/3 or more of patients will remain happy and surgery-free 5 years or more if they engage in a non-surgical program with a rotator cuff tear. Not many people know that. So the MRI can be helpful, for example, to show rotator cuff tear, but it also helps us age the timing of that rotator cuff abnormality. If I can determine that that tear has been there for some period of time based upon the features on the MRI, you may be surprised to learn that non-surgical intervention can be very successful in eliminating your pain and normalizing your function. If, however, we can't get you to rebalance and re-strengthen the shoulder and eliminate the inflammation, then surgery can be a very good option to treat a rotator cuff tear. Surgery for rotator cuff tears, whether they're new onset, what we call acute tears, or managing long-standing tears that recently became symptomatic, is pretty straightforward. It involves an arthroscopic procedure done through a small camera, typically through 4 or 5 1-centimeter incisions. At the time of surgery, we identify the abnormalities, we repair the tendon back to the bone with a technique that is considered the strongest relative to the biomechanics when we've looked at this in the laboratory. We repair the tear typically with a number of suture anchors placed in a strategic fashion to maximize the strength of the repair. The surgery takes less than an hour. It's often done in a sedated patient who we simply numb up the arm so they have no surgical pain for at least 6 to 8 hours after the surgical intervention. At times, there are other abnormalities seen at the time of surgery. For example, the biceps tendon can be a pain generator, where patients will complain of pain in the anterior aspect of the arm. So on occasion, we will do a procedure called a biceps tenodesis, where we actually will cut the biceps and fix it to the front of the humerus. That's another way to eliminate any pain generator while maintaining the cosmetic appearance of the arm and strength. Sometimes there are bone spurs off the scapula or the acromion, and sometimes the acromioclavicular joint, the joint on top of the shoulder, will be painful, and that will be addressed too at the time of rotator cuff surgery. Post-operatively, patients are placed in a sling. The sling is maintained other than for showering, hygiene, and physical therapy. I allow patients to remove that sling at 2 weeks post-operatively at night. They might be asked to wear it for another 4 to 6 weeks from the date of surgery. If you want to learn more about the specifics of rotator cuff rehabilitation, I would ask you to go to my website, briancolemd.com.
The best orthopedic care starts with the best orthopedic research. I am a proud faculty member in the Department of Orthopedic Surgery at Rush University, home to the Midwest's largest team of bone and joint scientists. With surgeons and clinicians partnering with elite laboratory researchers and data scientists, we continue to devise new solutions that push the boundaries of what's possible in the treatment of musculoskeletal conditions. Our work informs orthopedic care around the world and is fueled by donors, patients, and families who believe in our research to help more people lead active lives free of pain. To learn more about opportunities to participate in research or become a supporter, please ask a member of my team or visit our website at this address.